Bismillahirrahmanirrahim. Assalamu alaikum, everyone. Happy UAE Flag Day. Welcome to our Emirates Society of Internal Medicine meeting. NOACs as a standard of care in DVTPE management. Myself, Dr. Abi Al-Haj from Rashid Hospital. I would like to introduce my speakers for tonight, starting with the first speaker, Dr. Muhammad Tariq Bakri, who is a graduate of University of Damascus in 1990. He holds American Board of Internal Medicine. He's a clinical assistant professor at Michigan State University College of Human Medicine. He's an internal medicine senior consultant at SKMC. He is a winner of multiple best teaching faculty awards in USA and United Arab Emirates internal medicine residency program. He chairs many committees, including Anti-Coagulation Task Force Committee, Internal Medicine Improvement Steering Committee, and Internal Medicine and COVID Guidelines Committee. His talk today is titled VTE Patients with Active Cancer. The second speaker of tonight will be Dr. Waqar Haidar Gada, who is a senior internal medicine consultant and a at SKMC Abu Dhabi. He's an adjunct clinical assistant professor at University of UAE. He's a former foundation training program director. He's an honorary senior lecturer at Leeds University and King's College London. He was awarded many clinical excellence awards and prizes. His talk will be about VTE in elderly with renal impairment. With that, I will ask all the audience for any questions. Please to post them in the chat box. We'll be having a question and answer after the two topics. And I would like to leave the mic for Dr. Muhammad. You can start, please.
Yes, I'm going to share my screen. Okay. Good evening. Thank you, Dr. Abir, for the introduction, and thank you for inviting us to this scientific meeting. Today I will talk for 20 minutes about cancer-associated thrombosis, which is a topic it's been developing more and more in the last 2 to 3 years, with new guidelines coming, especially in the last couple of years. Sorry. So my objective today, 3 objectives. The first one is to recognize that thrombosis is a very common complication and major cause of morbidity and mortality in patients with cancer. Second objective, to review the highest risk factor for VTE in patients living with cancer, which needs to be considered in the decision-making when it comes to the duration and the type of treatment, as you will see in the guidelines. And also to emphasize now that NOAC is currently one of the first line in the majority of cancer-associated thrombosis, of course, after weighing the benefit and the risk and have fully informed patient preference. So we all know that VTE in general is a serious disease with significant morbidity and mortality with significant complication. That's just VTE. And if the patient has cancer, the patient is fighting for his life with a lot of mental and physical stress. If the patient gets really VTE on the top of malignancy, imagine the problem he's in and the stress he will be in. Here you can see that when we look at cancer outpatient mortality, 71% of the cancer patient die because of cancer progression. And as number 2 comes tie between infection and VTE, 9% each. And for inpatient cancer patient, usually sudden death is the most common cause for sudden death is fatal PE. So just a few slides about the VTE risk and the natural history of cancer. We know in cancer, the coagulation system is highly activated, and there is many reasons or mechanism for that. You can see some of them on the list: venous stasis, damage to the endothelium, expression of procoagulant proteins on tumor cell surface, activation of inflammation responses. So as you can see, really VTE in cancer patient is common complication. The good things, hopefully, is to prevent it and treat it effectively by early diagnosis. You can see that 15% of the patients with cancer will have symptomatic VTE, but the striking thing here that up to 50% will have really asymptomatic VTE. It will be incidentally discovered when we're doing diagnostic scans or follow-up when we see the clot. So it's very important to always keep in mind that cancer patient is at higher risk. And if the patient has any vague or non-specific symptoms, to consider ruling out VTE, especially the thrombosis we see in unusual localization like splenic vein thrombosis, portal and hepatic thrombosis. Sometimes they can just present with vague abdominal pain and GI symptoms. And as you're aware of, VTE can be the presenting sign of occult malignancy. So 10% with idiopathic VTE develop cancer within 2 years. So it's very important to have a very good history and physical to search for any red flag signs and symptoms, and close follow-up for those patients, especially in the next 2 to 3 years after the diagnosis, and do the routine screening malignancy tests. And if the patient has recurrent idiopathic VTE or bilateral DVT, high suspicion, as we said, from the history and physical, strong family history, we really need to do some extra workup to rule out malignancy. And it's not only it's fatal, it also has negative impact on quality of life. You can see VTE can delay the treatment or trigger change in cancer treatment regimen, prolong hospitalization, compromise outcomes after surgery because they are at higher risk for VTE after surgery. And here you can see the natural history of cancer in relation to VTE. The black line is the risk of VTE in general population. The minute we have malignancy diagnosis, regardless of what kind of malignancy, the risk go at least 4-fold. And during the journey of the patient with cancer, the risk goes up and down according to some risk factor, as I will mention in the next few slides. So the risk factor really, basically, we can simplify it into 4 groups: patient-related, which is comorbidity, prior VTE, thrombophilia, or tumor-related, like the type of cancer, the stage of cancer, and time since cancer diagnosis, or treatment-related, if the patient gets hospitalized, surgery, chemotherapy, hormonal therapy. If the patient has, most of the patient will have central venous catheterization, which will make them at higher risk, and also some of the biomarkers, in particular the D-dimer and the P-selectin. So quickly, in for a few slides, you can see here the VT risk by time from cancer diagnosis. You can see it's the highest in the first 3 months, then start going slowly down. But overall, the first 12 months after the diagnosis of cancer has the highest risk. And regardless of male or female, the highest risk comes in when the patient advanced age. And also for VT recurrence, the peak recurrence usually in the first 6 months, then the second 6 months, and start going down after. We talked about cancer types. You can see the highest risk for VTE is pancreatic cancer, brain cancer, AML, upper GI like stomach and esophagus. The second group, which has a little bit lower risk, but higher than the rest of the cancer, kidney, lung, ovarian, liver, and lymphoma. Luckily, for the most common cancer we see in our practices, prostate cancer, breast cancer, it has a little bit lower than the rest of the already mentioned. And tumor stage is very important. So patients with metastatic disease have 20-fold risk of VTE compared with local cancer. So it's very important to keep all of this in mind when we decide about treatment and duration. As we said, surgery, cancer surgery will increase the risk of VTE in cancer patients, especially specific surgery, especially in the upper GI area, pancreatectomy, esophageal resection, gastrectomy, and so on. Chemotherapy by itself, whenever the patient goes into chemotherapy, it will increase the risk even more than the baseline for cancer. And it depends also on the chemotherapy and the cancer treated. So here, a list of the highest risk factor to really try to keep it in mind. Older patient, pancreatic, brain, upper GI cancers, metastatic disease, first 3 months after cancer diagnosis, first months after surgery, and as we said, after initiation chemotherapy, especially the one mentioned here, cisplatin, treatment for multiple myeloma, and other treatment. So anticoagulation in patients with cancer-associated thrombosis is really a major challenge. Here you can see that the patient with VTE in cancer comparing to VTE without cancer, even when they are receiving anticoagulation, the risk of recurrence is much higher, and the risk of major bleeding, regardless of what anticoagulation the patient is receiving, is higher. Also, they are at higher risk of fatal PE and fatal bleeding. Making this is a big challenge for us when we treat it. Also, we know that VTE by itself, cancer by itself, has increased mortality comparing with general population. But when we have both on the same patient, the mortality goes sky high. So it's very important to consider better primary prevention and better treatment and secondary prevention. So as I mentioned, compared to patients without cancer, cancer-associated thrombosis has higher risk of first and recurrent VTE, higher risk of bleeding on anticoagulation, and higher risk of dying. So that's making it even difficult more than VTE alone, where we need to weigh the benefit and the risk. And as you will see in the guidelines, patients' preference after full detailed education will play a big role in the treatment type and also the duration. So let's go quickly through some guidelines and supporting evidence. Initially, all the study was comparing efficacy and safety of low molecular weight heparin versus vitamin K antagonists. And you can see that the low molecular weight is associated with significant reduction in the risk of recurrent VTE without significant increase in major bleeding, especially the clot and the CAT studies. So based on this, the old guidelines was always preferring low molecular weight heparin over warfarin. And there was not too much data about NOACs, so they were also preferring over NOAC. And you can see that was also reflected in the ACCP 2016. This article I like to share it with you because really it gives us what was going on in the mind of the physician and the patient. That was in 2018. The author wrote, really, you can see in the green box, not a clinic goes by where I don't hear, don't you have a pill I can take instead of a needle? That was really the concern of the patients. And also, you can see in the red table that at that time, the current guidelines was recommending the low molecular weight heparin, and there was always concern about compliance. Usually the first maybe few weeks, the patient is compliant, but later on, when the symptoms goes away or the duration starts getting longer and longer, the patients usually stop taking the medication on a regular basis and put them at higher risk. And that's also reflected here in the study with rivaroxaban or warfarin versus low molecular weight heparin. You can see that most of the patient will stay on oral than injection. And so like either NOAC or warfarin, because it's oral, it has lower risk of discontinuation. And that's also part of the factors we consider in our decision for treatment. Then, after that, there was efficacy safety of NOAC versus warfarin in the VTE in general, but there were a lot of patients with cancer part of the study, about 30,000 patients in all the NOAC study, which showed NOAC is associated with non-significant lower risk of recurrent VTE and major bleeding versus warfarin. And after that, there was a lot of real-world study. Here, in the case of rivaroxaban, there was a few studies where it showed also NOAC is a good option for cancer-associated thrombosis. And after that, in the last couple of years, we had the trial compared safety and efficacy of NOAC with low molecular weight heparin. Unfortunately, we don't have head-to-head study to compare NOAC to the other. It was only with low molecular weight heparin. You have the edoxaban in the study of Hoxsey VTE cancer, rivaroxaban in selected D, abexaban. We had two trials, the ADAM VTE and the recent one, the Caravego. I'm not going to go through the study, all of the study, but all of them had really showed that at least NOAC is as effective as low molecular weight heparin and sometimes better, but there was increase in the risk of major bleeding, but it wasn't in the fatal bleeding and it wasn't in the critical site like in the brain or retroperitoneal. So that's the reason we had the new guidelines putting NOAC as a first line. This study, if you can take a screenshot, I do recommend to really review it whenever you have time. It has really very nice tables looking at different guidelines. You can see on the right side, summary of those guidelines, and also tackling the prevention in hospitalized medical oncology patient, ambulatory medical oncology patient, and undergoing cancer surgery, treatment, of course, and also a special patient population, extreme weights, renal and hepatic impairments, patients with thrombocytopenia, unusual hepatic or portal or splenic vein thrombosis. So I do recommend you to really review it whenever you have time. As we mentioned, all the guidelines really put the patient's preference part of the decision, and it needs to be fully informed fully informed about the efficacy, safety, especially potential for interference with chemotherapy of various therapeutic options. So it's not just the drug-drug interaction which increase the risk of bleeding, also the drug-drug interaction which can interfere in the efficacy of the chemotherapy per se. And the patient really will be interested in this point, not only the other one. And of course, adherence is important in our decision. So quickly, I will just like this is summary of the National Comprehensive Cancer Network guidelines. This is the latest 2020. As we said, full education to the patient, individualized risk, looking at multiple things regarding contraindication, caution with medication, drug-drug interaction, adherence, and so on, risk of bleeding. And you can see that in 2019, it was edoxaban alone as category 1, but now in 2020, they have edoxaban and abexaban as category 1 and rivaroxaban as category 2A, preferred over low molecular for patients without GI malignancy, because all the study really showed higher major bleeding when the patient had GI malignancy, especially the upper GI tract. The bigger trend comes as alternative, and for patients with GI malignancies, they preferred low molecular weight heparin over NOAC after discussing with the patient. Of course, if there is a failure, for the sake of the time, I will not go through each one of them, Of course, if you're of the patient on low molecular weight heparin, we always have to consider HIT as a reason of recurrence. Otherwise, we can increase the dose. If the patient on once a day, do it twice a day, increase the dose 20 to 30%, or switch to fentaparinix, or switch to NOAC if the patient on low molecular weight heparin. And this is the second guidelines, which is American Society of Clinical Oncology 2020. Again, putting the NOAC in the form of edoxapan or rivaroxapan with low molecular weight heparin as equal after discussing the risk and benefit, after discussing the cancer site like upper GI or GI malignancy versus not, drug-drug interaction, and so on. So it's exactly almost the same as NCCN. So I don't want to really spend too much time because I have only 20 minutes. But for the duration, all the guidelines really, if the patient has low to moderate risk of bleed, usually recommended to keep the anticoagulation while the patient has active cancer, or the patient continue to be on chemotherapy or hormonal therapy. And again, this decision needs to be dynamic. It's not like one-time decision. Every time we see the patient, we have to always assess the benefit and risk to decide about to continue or not. ICTH 2018, which is a little bit now old comparing with the 2020 guidelines, but it has also the same concepts. So no, I don't need to repeat it. Also, the Canadian expert consensus also has the same concept. You have to go through some factors to decide what's the best for the patient, then inform the patient and decide about the treatment and duration. And they have very nice algorithm to go step by step. I don't have time to go through it all, but it's the same concept. I put a couple of slides just to go to give you an idea about really the trick regarding drug-drug interaction and chemotherapy. So there is some anti-cancer therapy which can increase gastrointestinal toxicity and will put the patient at higher risk of GI bleed. So in that scenario, sometimes if the patient is willing to go for injection, low molecular weight heparin will be the best for that patient. Also, there is a lot of drug-drug interaction with a lot of chemotherapy. So this is where really the role of a clinical pharmacist, or in particular hematology oncology clinical pharmacist, can play a big role to help us about this. A couple of more slides. This is the latest published regarding NOAC versus low molecular weight heparin. The Canvas study published in May 2020 in the American Society of Clinical Oncology. So it was comparing a non-inferiority comparison regarding low molecular weight heparin, fentaparinix, and fractionated heparin to all the available NOAC and to warfarin. And you can see that the conclusion was among adult cancer patients with VTE, the use of NOAC or DOAC compared with low molecular result, it was similar efficacy, so non-inferior risk for recurrent VTE, and with no difference in the rate of bleeding or death in randomized patients. So that's also give us a little bit more confidence in using NOAC in cancer-associated thrombosis. Couple of study is going on. We're waiting for the result. The second one, the multi-international apixaban cancer-associated thrombosis study, examining the apixaban 2.5 milligram BID to compare it with the 5 milligram BID when we go beyond 6 months. Because till now, we don't have any study to support really reducing the dose, like in the case of rivaroxaban. Usually after 6 to 12 months, we can go to 10 milligram apixaban to 2.5 milligram BID, but it's not recommended in cancer associated at this time because they have very high risk for recurrence. So it's better to stick with the regular dose. So final slide, it's really, I mean, cancer-associated thrombosis is a topic which is now a little bit more clear than a few years ago. NOAC is now one of the options to consider versus low molecular heparin after going through a few things regarding bleeding, efficacy, weighing benefit risk, looking at drug-drug interaction, looking at patient-informed decision, and I think it's really needs to be as possible as like MDT or a group decision between the primary care physician, IM, hospitalist, thrombosis specialist if available, the oncologist and clinical pharmacist to see what's the best for that patient in particular. So it's case by case, and then talk to the patient, give him all the information and get the decision because as we said, adherence is also very important. So with this, I will finish and hopefully I didn't go over time.
Dr. Waqar, would you like to start, please?
I will stop sharing. Thank you.
So can you see all my slides now? So, Reen?
Yes.
Yes, can you see my slides now?
Yes, can you please start?
So, okay. Thank you so much, Emirates Society of Internal Medicine, for giving me this opportunity to talk about very important topic of VTE in elderly and the patients with renal impairment. Again, it's a huge topic, which I'll try to cover as much as possible in next 20 minutes or so. So without further ado, I'll move on to my next slide. So objectives of my session today would be, we'll first talk about the VTE in elderly. We'll then talk about break it in DOAC in elderly. We'll then talk about VTE in renal impairment, then DOAC in renal impairment, and then combining them all together, thinking about that how the DOACs can be used in elderly and renal impairment. And then questions and answers, maybe we could leave it to the end. Okay. So in your slides, you can see on your left, okay, this is a big DVT. This is one of those which you should not miss. There is no doubt this is an extensive DVT, as you can see, and also so on the right, you can see the extensive bilateral PE. So we're not going to talk about much about what DVT and PEs are, but let's talk about what we said about VTE in elderly. Now, this is a nice slide which you can see on the right side, the bar gram. What it tells you is that the incidence of VTE increases as your age increases. So as you can see, slowly and steadily, your VTE risk as you're growing older goes up and up. So the ones which the closed boxes, the bars, black ones are the women and the other ones are the males. As you can see, up to the age of 60, you have more incidence of VTE in women. Okay, understandably so, because of the pregnancy, because of the oral contraceptives or hormonal relations. As you go above 60, you can start seeing the male VTE incidence goes up and up until it becomes, if it's very old, again the women becomes more. The reason probably being because the women tend to live longer, they have more life expectancy. So this is a nice thrombosis research article by Frischler, who has done a lot of work in VT in elderly, and what way, if it depends how you define elderly. So if we are saying the patients are above 65 years old, we have more than 60% of the VTE events. So elderly get more VTE than having the younger population. But when they get it, they also get more higher mortality and morbidity as well. This is a busy slide. This is from Swifter study. I want you to just take it with me one by one. So first of all, if you see from lower side, the graph, the bar graph, you can see that in patients, the blue represents patients less than 65 and the pink represents patients above 65. So you can see that again, the mortality is less in less than 65 patients, and the mortality is almost double with a p-value of 0.033 if the age becomes more than 65. Similarly, the patients who require this VTE treatment, they get more bleeding if they are elderly. So not only it's more common, it's more mortality, but also causes more bleeding as well. So you get it more in elderly, the patients get more hospitalized, you have a higher rate of massive PEs. When you get massive PEs, they are more lethal as well, and massive PEs, they're life-threatening in elderly. So let's try to look at the risk factors of recurrent VTEs. So in elderly, it also comes back again. So you have more chances of having a recurrence. This is from Saudi, from Riyadh, looking at the 277 VTE patients, and 14% you can see were diagnosed with recurrent VTEs. So you can see that 1 in 5, so it's a big number, 1 in 5, the ones who got recurrent VTE group actually died. So the ones in comparison to one, only 4% in with no recurrent VTEs. So in elderly, it's more lethal, higher mortality. When it comes back again, you have a more mortality as well. The malignancy and surgery were the most important clinical risk factors. In summary, talking about VTE in elderly, if we take it, we're talking about more common in the elderly. We're talking about high mortality, and if it comes back more, and if it comes back, it's even more lethal as well. So let's in next few slides talk about DOAC role in elderly. So this is a meta-analysis from the randomized control trials. You can see 10 randomized trials were included with 25,000 elderly participants. This was an earlier study in 2014, essentially talking about that if you have elderly patients above 75, NOACs did not cause excessive bleeding and were associated with equal or greater efficacy than conventional therapy. Just a suggestion at this stage, we're talking about a few years ago, like 7 years ago, talking about that DOACs can be beneficial because they have a lesser bleeding. Okay. Similar article in Thrombosis published nearly the similar time, a few months later, talking about comparison in all the trials done for VT trials, and look at this 18%. So the most what the elderly population was in Einstein DVTPE study, similar percentage in other studies as well. So there was 1 in 5 patients were above 75 years old. So what we are looking at looking at the efficacy of DOACs in the elderly. As you can see that overall the confidence intervals are large, though in dabigatran, rivaroxaban, apixaban, edoxaban, all of them were favoring, as you can see, favoring towards DOAC, with more significance in edoxaban in above 75 years old. But the journal trend was that they are more efficacious than VKA. So were they having lesser bleeding as well? So this was like, you can say that they're more efficacious, but what about the bleeding? So you can see from dabigatran, again, it's more towards favoring DOAC, okay? Rivaroxaban, again, greater than 75 years old, you have a statistical significance. Apixaban, both less than 75 and above 75. Again, in Dabi, Riva, edoxaban, all favoring towards DOAC. So essentially, it's more efficacious. The trend is more towards efficacy. And in major bleeding and clinically relevant non-major bleeding, you have some statistical significance as well. Just these articles, the review articles, I don't want to spend much time, but again, the Critchler again, quite recently in last year, March, tried to look at the VTE, so look at the DOACs in elderly population. 2019 ESC guidelines actually changed it in a way that they have grade 1 recommendation about oral anticoagulations, DOACs being the first line treatment for PE patients. And the American Society of Hematology 2020 guidelines actually said we should be using DOACs over vitamin K antagonists patients who have got DVT or PE. So they have more recommendation over the VKA antagonists like warfarin, but there was no suggestion of one DOAC using over another as per ASH Society of Hematology 2020 guidelines. So, in summary, for DOAC in elderly, yes, you can use them. Yes, they are at least efficacious. Rather, there is some trend towards suggesting that they may be more efficacious than the VKA or low molecular heparin, and they're certainly having less major bleeding in elderly population, contrary to what we normally believe. So a few slides on now talking about VTE in renal impairment. So this is a French study talking about the VTE is highly frequent. So renal impairment is highly frequent in VTE patients. It's strongly linked to VTE and it's one of the risk factors for cardiovascular morbidity and mortality and fatal PE. So what we're talking about that if you get a renal impairment in VTE, they are very strongly linked, and it's one of the risk factors that you might get a more mortality, more morbidity, and maybe fatal PE. So how about using DOACs in these renally impaired patients? This is the same article which we used for published in Thrombosis Journal, which we use for elderly population. In this time, we're using it for all the DOACs and looking at their creatinine clearance. So again, you can see the creatinine clearance less than 50. Here's the DEBI, okay? And you can see rivaroxaban less than 50. You can see apixaban and edoxaban. Very similar trend what we saw in the elderly population as well, where it's favoring towards DOAC, some more than the others like DEBI, which is renally excreted, but there is a clear trend towards using DOAC for even the renally impaired patients with less than creatinine less than 50. So now this is next article from, if you go into more detail about looking at the rivaroxaban from Rupert. So Rupert looked into more details on Einstein DVT and PE study in 8,200 patients. So let's look at more closely this graph, which is upper, the bars, which you can see from the side where my cursor is going. So you can see that as we go from normal renal impairment to the moderate to severe renal impairment, you have generally the VTE recurrence goes high, high, high. So essentially, what we are saying is that if you have more renally impaired patients, your VTE recurrence rate is higher. But the VTE recurrence rate is actually lower than in all the population of whether renal impaired, normal renal impaired, mild or moderate to severe. Your rivaroxaban is lower than its counterpart of enoxaparin and VKA. How about major bleeding? This is even more interesting. So as you can see that as you're going from normal renal function to moderate to severe renal impairment, your risk of major bleeding is going up from all the way from 1% all the way to 4%. But the risk, if you are using rivaroxaban, actually it stays around 1 to 1.5%. So that's not much. So essentially what we're talking about that for renally impaired patient, they are at risk of recurrent VTE. We can see that, we know this, we discussed this before, but the major bleeding risk goes up with enoxaparin and VKA in renal impaired patients, but not with the rivaroxaban. This was similarly duplicated by Prince, again showing that there is 73% relative risk reduction or 3.2% absolute risk reduction when compared in frail patient. How they define frail? So Prince defined frail population with above 75 years old, creatinine clearance less than 50, or low body weight. This is the same population we are talking about, which I've been given this topic. So 8,246 patients, as you can see that there is massive difference, like we said, 73% relative risk reduction between the patients who have been using enoxaparin, and blue are the ones who are using rivaroxaban. So is statistically significant for frail patients using for VTE the rivaroxaban. Now, another article from the meta-analysis, let's look at the systematic review and meta-analysis. This is published this year in February, so there are lots of articles coming through. As you can see, this one, some of you might know about Bashir Mustafa, our own physician before in SKMC. So what he's talking about, the 3 randomized controlled trials they looked into, and the DOACs had significantly lower risk of major and non-major bleeding, irrespective of the level of renal impairment. Again, confirming what we just discussing, that even if you're renally impaired, your risk of VT goes up, your risk of major bleeding goes up, but not with DOACs. Busy slide again, the 2 articles. Let's talk about the systematic review and meta-analysis on the left. On the left, you have a very recent article in April this year. Again, the China study looking at the warfarin compared with DOACs. Very similar again. What we are trying to establish, what they said that DOACs significantly reduce the risk of stroke, systemic embolism, or VTE by 1/5 and major bleed by 17%. So if you compare each DOAC with warfarin, apixaban was the one striking out here, significantly better risk reduction of stroke, systemic embolism, and VTE 25%, and major bleeding 35% reduction than warfarin. Compared with warfarin, other DOACs again significantly reduced in patients with CKD stage 3 and reduced the major bleed by 31% in CKD stage 4-5. So in conclusion, from this meta-analysis, systematic review and meta-analysis again, what they're talking about, the DOACs overall were better efficacy in early CKD and even similar efficacy if we talk about dialysis patients or stage 4 to 5 dialysis, stage 4 to 5 CKD. Contrary to what we generally believe that maybe for VTE, DOACs are no when you go more towards stage 4 or stage 5. These studies or meta-analysis suggesting that they have a similar efficacy and safety outcomes even in these patients as well. But of course, we need more randomized controlled trials for DOAC use in patients with CKD and dialysis patients, and maybe head-to-head comparisons as well. Now, one of these on the right, again, very similar, again, systematic review and meta-analysis, this time 7,286 studies, big studies. Again, they found no difference between DOACs and warfarin for reducing recurrent VT and bleeding events in moderate CKD patients. So what they're saying that equally warfarin, DOACs can be used in these moderate CKD patients. No significant difference between apixaban and warfarin in dialysis patients. So although it seems that there is no difference, that means you can't use it. It's actually on the other side. What we are saying is that contrary to what we believe, the DOACs may be used in these patients which we have not yet. Apixaban may be used cautiously as an alternative in acute VT treatment in severe CKD patients, but there is an insufficient evidence for using the others so far. But the suggestion that using DOACs against the potential bleeding risk in patients with CKD is potentially doable. So, in summary of VTE in renal impairment and using DOAC in renal impairment, DOAC at least equally effective in CKD patients. There is what we discussed, that there is a low risk of major bleeding or clinically relevant non-major bleeding with patients using DOAC in VTE in renally impaired patients. But we do need more randomized trial, and some of them are coming, but there's no head-to-head comparisons yet. One of the last few slides, very busy slide again. I thought to take this as an opportunity, again, a very recent article for April 2021. So let's combine this all together, okay? So I want you, so again, don't focus much on the slide as such. Let's take it one by one. So I want you to focus, first of all, on figure 1. So let's talk about figure 1, comparing the patients. Here they compared VKs and DOACs, okay, or parenteral, in elderly population or less than 75. So what we're talking about, that the use of DOAC, whether age less than 75 or above 75, remains the same or similar more than 50%. So this was done in recovery DVTPE study, and they looked at the characteristics of these patients. So they found that the patients, 12 to 13 patients, were elderly, and 1/4 had mild to moderate renal impairment. Despite that, you can see the use of DOACs in both population was very similar in elderly and less than 75 as well. Now, look, how about the renally impaired patients? Again, you can see that as your renal impairment goes lower, so you have creatinine clearance is lower and lower, you have tendency, obviously, to use of DOACs goes from 58.5% goes lower, lower, and lower. Okay, so as the creatinine clearance goes low, you have lesser use of DOACs in these patients. Now, let's have a look at the figure above. This is a busy slide, but I'll take you through. What we are saying is that regardless of the age of 75 or above 75, you can see the use of DOACs has obviously gone down when creatinine clearance goes down, and here as well. But when you compare with age of less than 75, you have 33%, so 1 in 3 using DOACs, but more than half actually using DOACs in above 75. So what we are concluding is that decreasing in renal function, particularly in the subgroup with creatinine clearance less than 30, is related to less DOAC use, but not older age. So was associated less use of NOACs. So NOACs can still be used or being used in elderly population above 75, or you can see here as well. But yes, when you have lower creatinine clearance, less than 30, obviously the DOAC use, regardless of the age, goes lower and lower. So one of the last slide, meta-analysis of 22,000 patients. This is really hot off the press. You can see in September 2021, less than 2 months ago, where DOACs were, say, in the meta-analysis, it shows that DOACs were associated with a borderline higher efficacy in women, a significantly higher efficacy in patients with age more than 75 years old, and creatinine clearance less than 50. Major or clinically relevant non-major bleeding, what we talk about safety, were significantly reduced in DOAC as compared to VKAs in both patients with age less than 75 or more than 75. So what we are saying is the DOACs are highly efficacious even with the age more than 75 and less than creatinine clearance less than 50. And the major bleeding points in both population, whether it's less than 75 or above 75, you have a very advantage of these DOACs. Decreased thrombosis and bleeding events, especially with patients with more than 75 and creatinine clearance less than 50 were observed in this study. So again, to summarize, in total, using of DOAC in elderly and the patients with renally impaired, what we are saying is that we have a higher efficacy in elderly and renally impaired patients. We have major bleeding or clinically relevant non-major bleeding reduced in both age less than 75 and above 75, and renally impaired patients or renally not impaired patients, in both of them it was decreased. I will finish here. Hope I was in time, so I'm happy for questions rather in the end or whenever required. Thank you.
Thank you, Dr. Mohammed, and thank you, Dr. Aqar. I have a few questions here. The first question goes to Dr. Mohammed. Dr. Mohammed, you have mentioned in one of your slides that 10% of VTE occurs up to 2 years, and you have suggested that it requires a close follow-up. Can you just clarify more how to do that? Is it by blood investigations or scans?
Yeah, so I think, as we said, when we have really what we call idiopathic VTE or unprovoked VTE, we always need to be to really have a very good history and physical, because if there is any high suggestion of malignancy, then we really need to do it right away to rule out malignancy. But not every first idiopathic VTE we really need to go ahead and do full, like pan CT and so on, especially in young people. So in elderly people, high risk, family history. If the presentation, as we said, upper extremity DVT, bilateral, whatever, then sometimes we really need to do it right away. But, so for those patients who is really idiopathic, but they don't have very high suspicion of malignancy, we should really just, keep in mind that in the next 2 years, they might have some, the malignancy can show up. So that's the reason I said it's a close follow-up. And at the same time, we should really always do the preventive screening for age appropriate, like mammogram, colonoscopy, whatever, according to the age one. But, here I can see in the practice, really, every patient comes with idiopathic VTE, even young patient, no really suspicion of malignancy, they get pan-CT, which not recommended as much as with what we do. But that's the reason I say the close follow-up, do the appropriate age screening, and in some population, we have to rule it out on the spot.
Thank you so much. Dr. Waqar, the second question is for you. It's in the chat box. When to adjust the rivaroxaban dose in elderly patients with CKD stage 3 or 4?
So as per the rivaroxaban recommendations, their own like drug recommendations, they talk about adjusting the dose when you have a creatinine clearance of between 15 to 50. There's no age recommendation for rivaroxaban, for instance. There is an age recommendation for apixaban, for instance. You have to have three things, and then you see age less than age greater than 80, weight less than 60 kg, or you have a creatinine clearance as well, EGFR less than 30, or creatinine more than 133. So, but for rivaroxaban, there is no age restriction or no age recommendation. So it's only the creatinine clearance, in which case you will go down the dose, or rather than having for this is we're talking about AF. Okay, if we are talking about VTE again in the renally impaired patients, it depends. There is no age recommendations for VTE.
Okay, what about the dose adjustment? Can we use it down to dialysis patients?
Can we do, sorry?
Can we still use DUAX on dialysis patients?
Yes. So as I showed you, there is a lot of data and meta-analysis being done for these, although the numbers are low, but these can be used, like apixaban already being used for dialysis patients. There is more and more data for edoxaban as well as for rivaroxaban to be used in dialysis patients as well. But again, I would say that it will be very soon be a common thing to do, but you have to assess the patient's bleeding risk as well as the VTE risk as well. So yes, you can use it, but you have to balance the benefit and the risk of the bleed.
I add something here. As Dr. Waqar said, it's very important to really differentiate for the dose atrial fibrillation indication from VTE, because in VTE, even with the creatinine clearance down to 15, less than 15 is really not recommended and to be avoided. But above 15 for VTE, still the dose exactly the same, which is the loading dose 15 BID for 21 days, then 20 milligram. That's for rivaroxaban. So it's very important to really know the dosing. And if any doubt, always we need to double check because dosing is very important.
Dr. Mohammed, what would you recommend? Sorry, do you recommend therapeutic treatment for subsegmental PE in active cancer patients?
In active cancer patient, yes, because they are really at very high risk of VTE. So subsegmental in somebody with high risk, yes, we treat. For somebody with low risk of recurrence or low risk of VTE, many of the guidelines, they give the option of to treat or not to treat, because sometimes subsegmental can be just incidental finding. But if the patient is symptomatic and cancer, definitely needs to be treated.
Okay, there's one more question, if you don't mind. For central line thrombosis, do you advise removing or changing the line, or just to continue on the anticoagulation?
Yeah, so I just gave a presentation a week ago about catheter-related thrombosis. So basically, they are at high risk because they have especially in malignancy. So they have double whammy, what we say. So they have the malignancy and they have the catheterization. So usually, if we have to decide to remove or not to remove, we have to go through multiple factors. We don't have to remove the catheter unless it's not functioning well. If we need it, of course, if we don't need it, it's always better to take it out. But if we still need it, its function, its positioned very well and not infected. So then, yes, we will keep it and we will keep giving the anticoagulation. With malignancy and catheter-induced, most of the guidelines really recommend, unless very high risk of a bleed, to continue the anticoagulation while the patient has the catheter. And 3 months after we take the catheter away.
Dr. Waqar,
Yes.
one of the questions in the chat box, why some physicians use the term NOACs, the others use DOACs?
So,
Sorry.
well, this is as simple as it is that it used to be novel oral anticoagulants, and now we're talking about direct oral anticoagulants. Still, you can see that because lots of studies and research and everything they mentioned, so they are both interchangeable. So there's nothing wrong with using either of them, I would say.
Okay, one more question for you, Dr. Waqar. In the setting of mixed connective tissue disease with renal disease, do you recommend starting VTE prophylaxis?
So without having VTE, you mean?
Yes.
So the patient hasn't got a VTE, they're just having high risk of VTE.
Yes.
So again, if you are inpatient, yes, you will use it as a prophylaxis, but not as a long-term prophylaxis for just having so you have a connective tissue disease and you have renal impairment. That's not enough for you to counterbalance the bleeding side effects for these patients. So I can take Dr. Bakri's comment, but from my side, if the patient is not inpatient and there's no other risk factors for VTE, I will not leave them on prophylaxis dose forever.
Agree. Yeah, basically, if they develop one episode of VTE, it's considered as minor trigger, and there is chance to go for extended, but not without any incidence of VTE.
Okay, the last question in this part is, Dr. Bakri, it's for you. It was in the chat box. What is the dosing of anticoagulation for these patients with active cancer?
So this is always debatable and controversial question. So for NOAC, DOAC, whatever we call them, most of the patients feel comfortable up to 120 kilo or BMI up to 40%. Beyond that, we don't have enough data to really say we can use or not. There is no data to go against using NOAC in even weight above 120 or BMI above 40. And actually with the edoxapan in particular, in their atrial fibrillation study, they have very good number up to 150 kilo. So now we might get more information, but for now, for somebody who's really high risk, maybe, and the patient will agree and will be adherent to warfarin, then I think it's better to go with warfarin. So again, case to case, depend after the discussion with the patients.
So
if we use DOAC or NOAC in such patient, the recommendation to really do a drug level peak and trough, but unfortunately, it's not available in every center.
So, Abir, I would just like to add, I think what we completely agree with what Dr. Bakri said, it's case to case basis. But remember, I have to also, in my mind, have to check that what's the compliance for this patient is going to be with warfarin and time to therapeutic range. So if we are talking about less than 50% of PTR for warfarin patients, so let's say we start them on warfarin and they're not going to be within the range most of the time, it's better to then ask them that should we use DOAC in you, because if you're not going to be compliant with this, okay, with warfarin and INR checking and all that, it's better to use then DOAC in those.
Yeah, and one more point, it's very important in such population not to reduce the dose, like for rivaroxaban to go to the 10 milligram or apixaban, the 2.5 BID. It's better in such cases to continue with the full dose.
Thank you so much, Dr. Bakri and Dr. Waqar. I think Dr. Bahr al-Hamsi is waiting and he's checking the time as well. By this, we ended the educational session. We're going to move on to the next session, which is Rising to the Challenge, Managing Acute and Extended VTE Treatment What can we learn from complex case studies with Dr. Bahar Hamsi, who is a consultant physician and program director of the Internal Medicine Residency Program at SKMC. Dr. Bahar, please start.
Thank you, Abir, for inviting me for this scientific meeting. I really enjoyed Dr. Waqar and Dr. Al-Bakri lecture. There is not much I can say after them. They are very good speakers. Today, I'm going to talk about the baseline of how to approach a VTE. We're going to talk about some statistics, complication, guidelines, recommendation, and then we'll end up with some studies with some of NOAC. So we all know that most of the DVT comes in the distal veins, but sometimes it happens in the proximal veins, especially after trauma or surgery. And when the blood clot travel up to the lungs, it block the arteries and cause PEs. But there is like some diseases can cause PE per se in the lungs, especially we can see it now also in the COVID era. The statistics about VTE is very important. There's like 300,000 cases of death in the United States each year from VTE. In Europe, 500,000 persons died from PE every year. Worldwide, there's like 3 million deaths each year. And it kills almost like 4 to 5 times more people in the United States each year than breast cancer. And actually, indeed, it kills more than AIDS, breast cancer, and highway fatalities combined together. So most important things about the VTE is the complication or the clinical consequences. As Dr. Bakri mentioned earlier, the post-thrombotic syndrome is very important. It happens in 15 to 20 or 50% of patients with DVT after 1 to 2 years. The issues about it is very debilitating complication of the disease. And right ventricular dysfunction is very important also because it is associated with elevated hospitalization and all-cause mortality. And lastly is chronic thromboembolic pulmonary hypertension, or what we call it stiff syndrome. It's fortunately it's having very low number of patients, only 1 to 3.8% of survival of PE, but it is a serious complication. And then we need to mention always that the quality of life of people who get VTE is not back to normal anymore, especially if it's not major provoked VTE, and especially because of the PTS and the stiff syndrome. And need to mention that the burden on the healthcare is very big, and we spend a lot of money each year on the VTE treatment and complication. So how good we are in the diagnosis the VTE. This study, like thanks God, is like old study. It was 1989. They found out on autopsy, 65% of the DVT was diagnosed on autopsy was not diagnosed by the clinical physician during the admission to the hospital. And for the PE, 70% of the fatal PE detected on autopsy were neither suspected nor diagnosed by the physician. So VTE often goes undetected until too late. It's like, this is like after autopsy. And how big is the problem? We don't know how many asymptomatic DVT we miss. We know that each year, this is a study from the United States, that each year they have 2 million symptomatic DVT, but we don't know how many asymptomatic DVT we miss in our practice. And from those 2 million, 800,000, they get PTS after 2 to 3 years or 5 years. 600,000 they get PE, and 200,000 die from that PE. So the problem is big, and the VTE complication is very serious. We'll talk about the 3 common ones, as we said, the PTS. The PTS happen like within 5 years of the symptomatic DVT. In Europe, estimated for 6,000 cases each year. It's debilitating disease because it causes pain, edema, hyperpigmentation, eczema, varicose collateral veins, and associated with significant quality of life reduction and morbidity and maybe surgery and admission to the hospital. And as we said, it also put a pressure on the financial healthcare in each country. The second common one, or like the second important one actually, is a chronic thromboembolic pulmonary hypertension, or the stiff syndrome. It's not common, as we said, but it is serious. It's associated with high mortality. 4 to 20% of the people die from stiff. The risk factor for it is like previous PEs, so people who has recurrent PEs, they are at risk factor for younger people. if the patient has larger perfusion defect on the imaging study, and if this is like idiopathic PE. Usually it starts or it goes unrecognized for years, and then the symptoms start to show up slowly. Patients start to feel like fatigue, weak, he has no energy, and then he starts to have exertional dyspnea, and then hypoxemia, and full picture of signs and symptoms of advanced right heart failure show up. This is, as we said, is very important to recognize early because it has high mortality for our patients. The third important issue about the PE is mortality. As we mentioned before, it kills a lot of patients each year, and the autopsy showed that 75% of people who dies from PE, they are from medical wards. So as we said, approximately 600,000 cases of PE per year, 2,000 died, 75% of those 2,000 in the medical ward. That's very important for us as a clinician, as like internists, to be aware about VTE and detect it early and protect our patients from getting the PEs if we can. This is another study to confirm the same findings. This is a study done in 3 centers, 2 from USA and 1 from UK, and it showed the same thing. Approximately 75% of the fatal PEs diagnosed at autopsy are in the medical patient. So this is put us as a physician in the front line to protect our patient, to diagnose our patient and treat as early as we can. So what are the pathophysiology and epidemiology about, Dr. Waqar just mentioned about the age. This study is like one of the big studies done in UK between 2001 and 2011. It included almost 26.9 million persons, and they followed them up for years. And they found out that male and female, no differences between them except in the very advanced age, that for each decade, each 10 years, there's increased risk of getting VTE. And the total risk was 131.5 per 100,000 persons per year. The interesting finding here that 58% of those VTEs incidents, they were unprovoked VTE. So just merely the age put the patient at risk for getting VTE. So we need to keep this in mind to add it on to what we learned from medical school about Virchow's triad factors, right? We all know that's the triad is endothelial injury, circulatory stasis, hypercoagulable state. When we talk about endothelial injury, we talk about venous disorders, venous valve damage, trauma surgery, or indwelling catheter, as Dr. Tariq mentioned in his presentation. Indwelling catheter is part of the risk factor. When we talk about circulatory stasis, left ventricular dysfunction, the patient after stroke, bedridden, venous insufficiency, and patient with like tumor or obesity or pregnancy pushing on the venous system. When we talk about hypercoagulable state, we talk about malignancy, sepsis, the first line, in pregnancy, estrogen, hormonal therapy, and inflammatory bowel disease. The other way of looking at those risk factors is to divide them to predisposing risk factor or the patient characteristics. This is what the patient comes to you. This is his past medical history. And the exposing risk factor is what is the condition or what the admitting diagnosis for your patient. So predisposing risk factor, as we mentioned before, history of VTE, patient has a chronic heart failure, advanced age again, obesity, immobility, stroke, and all this you can see on the right side of the slides. And the admitting or the exposing risk factor, why the patient come to you. He has a surgery, he has trauma, car accident, he came with acute medical illness, acute heart failure, acute respiratory failure, he has central venous catheterization, all the things. It's a predisposing risk factor. We can look at those as like a predisposing and exposing risk factor. Remember that, as we mentioned before in Dr. Tariq, cancer is a predisposing and exposing risk factor. The same thing for inflammatory bowel disease. Patient maybe has a BID before and he will come with exacerbation. So what is the diagnostic strategy for acute PE? When the patient comes to emergency room and the ER doctor or the internist in the emergency room seeing the patient, how we approach the patient to diagnose PE. You look at the patient in 2 ways. The best way is like hemodynamic instability or stable. So if your patient hemodynamically unstable, the best things to do for your patient is to do bedside transthoracic put the patient at higher risk that yes, he might have the PE. And then you go with your workup and you do the CT scan to rule out PE. If the patient has CT scan confirm the PE, then you start with treatment. But if your patient has no PE on the CT scan, or from the beginning he has no RVD, then look for another reason why the patient has hemodynamic instability. Because you cannot have massive PE with unstable patient and RVD and the right ventricular function is normal. So when you have massive PE, unstable patient, vitally unstable, you should have right RVD for your patient. So this is how we approach in the emergency room. If any patient come to the emergency room, hemodynamic unstable, the first things, do TTE. If RVD there, then go to CT scan to confirm your PE. What about patient who is stable? Then you can use the what they call it, the criteria for evaluation for probability of the PE. If he has low or intermediate clinical probability for PE, then do D-dimer. If D-dimer is negative, that's it. There is no PE. Look for another reason. If D-dimer is positive, then you go for CT scan PE to confirm. If it's confirmed, you treat. If patient has high probability and CT scan done, no PE, you don't treat, you look for another reason, PE confirmed by CT scan. So the difference here is the probability, high probability or low or intermediate probability for PE. So you start either directly with CT scan or you go with a D-dimer. So how about the, what we call it pulmonary embolism severity index? What we mean by this, why this score was made? This score to estimate the risk of 30 days mortality from PE. How we do that? By using prognostic variables. If we look here on the left side of the slide, the prognostic variables are three compartments. It's demographic of the patient, his age, his sex, his comorbidity is very important, and then his clinical presentation to the emergency room or to your clinic even. So how we calculate this, you take the patient age and then you add for each prognostic variable, there's number or you give. For example, like if your patient is 75, you give 75 for the age. If he has a cancer, you give him 30. If he has heart failure, you give him 10, and so on. But look at here, if patient has alternate mental status, you give him 60, and then you do the calculation. This is what we call pulmonary embolism severity index, and it's classified to 5 levels: low, very low, high, very high, or intermediate. And that will help you with 30 days mortality from PE for your patient. So if he fit, for example, in high or very high, his chance of dying from PE within 30 days is very high, between 10% to 24%. I'll give you one example we see every day in our practice. You have one patient come to the emergency room with shortness breath and maybe chest pain. He's 75-year-old smoker. He has COPD. He has history of lung cancer. You did a CT scan. He has a PE. His saturation is 89%. What his estimated risk of 30 days mortality from PE? If we add his age, you get to 75, then 10 for male, 10 COPD, 30 for lung cancer, and 20 for saturation less than 90. His total score is 145. He has very high risk of mortality within 30 days from admission. So this is how we approach our patient, how we think about our patient. Why we need this? Because we need to talk later on in this study about the extended treatment for the first or the index PE. What the risk for recurrence of DVT? As we mentioned also earlier in this study, in the presentation by my colleagues, that the recurrence is highest in the first 3 to 4 weeks of the first PE. So if somebody got a PE today, his chance to get another one within 1 week is almost 28%. And after 2 weeks is 15%. After 3 weeks, 10%, and so on. So the highest recurrence rate is in the first 4 weeks, but it will never go down to 0. Remember, it's still there. Whenever somebody gets a VTE, unless it's like major risk factor, it never goes down to 0. Remember this, even after 10 years, it's still there. The risk of getting another VTE is still there. So what are the other risk factors of recurrence VTE? Being idiopathic or getting idiopathic on presentation is one of the risk factors for recurrence. thrombophilia, primary DVT, increase in age, as we mentioned, each 10 years or each decade of in age, it increases the chance of getting VTE. A proximal DVT more than the distal DVT. Patient with a cancer, as we mentioned before. Residual thrombus mass is very important. How big is his first VTE? Being male more than female, and presenting with PE, it gives the patient likelihood to get another PE three times more than DVT itself. How about like treatment discontinuation? If you treat a patient with VTE with NOAC, as the doctors mentioned, it's very important and it's very effective medication. But studies show that after you stop the treatment, the risk of recurrence goes high. In the first 6 months, almost 6 or 7% of the people get another VTE. After 1 year, 10%, and so on. So recurrence after discontinuation of the treatment is very high. And that's why all the studies now talking about extended treatment for VTE. This is meta-analysis done by Dr. Kahin, as published in British Medical Journal in 2019. It's a very important study. He calculated or he looked at he did a meta-analysis for 18 studies, including 7,515 patients, and he looked at the recurrence rate of those people. The first year, the recurrence rate was 10.3%, second year 6.3%, but for the 2 years together, it's additive numbers, 16%. And from year 3 to year 5, 3.8% for each year, that come up with 25% for 5 years, and for 10 years, 36%. So as we said, it never goes down to zero, especially if it's not like major risk factors. So what about rivaroxaban, the treatment of VTE? We need to talk about evidence-based results. We need to talk about the studies. There are several studies done by rivaroxaban for the patient with VTE treatment or prevention. There's like 4 or 5 studies done. We call it Einstein PE, Einstein DVT, Einstein extension and choice. And it was also done on the cancer patients for treatment and prevention. I'm gonna touch base about Einstein DVT and PE. This is the full analysis for those 2 studies together. It included 8,281 patients. And they look at the recurrence rate of VTE in those 2 studies and the major bleeding in those 2 studies. And they found out that there is no differences. It's non-inferior between the rivaroxaban arm and enoxaparin and vitamin K antagonist arm. There's no differences in the recurrence of the VTE. And we found out that the treatment was as effective in the first 21 days. And we all know that rivaroxaban, they use 15 milligrams twice a day in the first 21 days. And this is like during those days, the risk of recurrence is the highest, as we just saw in the slides before. And when they look at the major bleeding between those 2 arms, they find that there is like 46% relative risk reduction in the major bleeding with significant p-value. How about Epstein extension? This is a rivaroxaban versus placebo. Patient who finishes rivaroxaban, they extend, and they compare it with the placebo. There is like very big significant differences between the 2 arms. Rivaroxaban decreased the rate of recurrence by 82% comparing to the placebo arm with significant p-value. But when we look at the major bleeding, there's no differences between those 2 arms. And the third one is Einstein choice. Einstein choice is a very nice one. It was done on people who has a VTE, who completed 6 or 12 months of treatment, and they randomized them to 3 arms. One arm received rivaroxaban 20 milligrams, second one received rivaroxaban 10 milligrams, and the third arm was put on aspirin 100 milligrams. And they give them this treatment for 1 year, and then they look at the result of the study. And the purpose of the study to show the superiority of the rivaroxaban arms comparing to aspirin arm. And the issues here is just to balance between 2 important things: to be off treatment or to be on treatment. If the patient is off treatment, you increase the risk of VTE recurrence, as we saw in the last few slides. And if you put it on treatment, you might increase the risk of bleeding. So balancing these 2 things was very important to look at in this study. And this is the result of that study. The study showed that both rivaroxaban doses, 10 milligram or 20 milligram, provide superior reduction in the recurrence of VTE rate comparing to aspirin. It was statistically significant findings. And the recurrent or the protection was very early in the study. You can see here the deviation between the curves was very early in the first 30 to 60 days of the study. But how about the major bleeding? If there's increase in the major bleeding, if you use rivaroxaban 10 or 20 milligram comparing to aspirin, the study also did not show any difference. It was very similar between the three arms with no significant p-value between the three arms. So the study conclusion was putting the patient on extended treatment with rivaroxaban was better in protection for your patient from recurrent VTE with no increase in the bleeding rate. And the last one here, this study was done by Dr. Coleman and was published in American Journal of Medicine in 2019. This is like a database analysis for a lot of studies. And this study was on provoked VTE. This is a real world, what we call real world study. And this was to demonstrate the efficacy and the safety of prolonged anticoagulation with rivaroxaban. So if we look here at all provoking factors, the difference between people who stop the treatment with anticoagulation and people who continue on rivaroxaban, the recurrence rate was very much different in the favor of continuing rivaroxaban treatment comparing to placebo, to discontinuing the medication. If we look at the major persisting or minor persisting or minor transit or major transit, always the results was in the favor of using rivaroxaban and not to discontinue treatment, because when you discontinue treatment, the recurrence of VTE was higher in those arms. How about the major bleeding? There's no difference between all the arms. There's no significant or no statistically significant differences between all those arms. So continuing with the rivaroxaban in the real world data supported the study of Einstein extension. So what are the guidelines now regarding extending treatment for patients with VTE? The European Society of Cardiology divided the people with estimated risk of long-term recurrence to three groups: lower risk to get another or like recurrence, intermediate, and high rate. So how they divided this? By looking at the risk factors for the index PE. What the cause of the first PE the patient get. If he has a major transit or reversible factors associated with less than 10-fold increase in risk for index PE, then the risk is very low, less than 3%. Like for example, surgery with general anesthesia more than 30 minutes, patient bedridden in the hospital for more than 3 days or 3 days or more, patient with trauma or fracture. Those people, they have major transit reversible factors, so they have low risk for recurrence. So recurrence rate is less than 3%. The intermediate category, the people who get recurrence between 3 to 8%, either transit reversible risk factor was associated with less than 10-fold increase in risk of first VTE, or non-malignant persistent risk factor, or no identifiable risk factor. Like patient has minor surgery, patient admitted to the hospital less than 3 days, pregnancy, using estrogen pills, long trip flight, leg injury without any fracture, inflammatory bowel disease, or active autoimmune disease. Those people, they have intermediate risk for recurrence between 3 to 8% per year. The high-risk people, they are three categories: people with cancer, people with antiphospholipid syndrome, people with recurrent VTE without major transit or reversible factors. So how you approach those people, how you treat those people after treatment. This is a recommendation in 2019 from European Society of Cardiology. To summarize this, if you have first episode of PE with no identifiable risk factor, or you have first PE with persistent risk factor, or you have PE with minor transit or reversible risk factor, it is recommended, or like it should consider indefinite duration of treatment, and that was given class of recommendation 2A, all of them. If you have patient with recurrent VTE not related to a major transit reversible risk factor, it is recommended to treat him indefinitely. This is the recommendation in 2019 European Society of Cardiology. So consider indefinite treatment for the first three categories. Indefinite treatment, it is recommended for recurrent VTE. And then when you choose your treatment, here is very important, like a complement of Dr. Bakri and Dr. Waqar presentation. If you want to extend your treatment, use the NOAC like Epixapan 2.5 twice a day or Rivaroxaban 10 milligram once a day after the first 6 months of therapeutic anticoagulation treatment. All this information were supported from the Epstein extension, Epstein choice, and amplify extension studies. So it is very important when you treat your patient with a PE to prevent him, or VTE to protect him from getting another one. The easy way to look at it, as we said, like the people relative risk of recurrence, if you have low risk, less than 3%, like major transient provoke, you don't have to give him extended treatment. If he goes with any other category, it is recommended to give him extended treatment. The duration of treatment, according to the European Society of Cardiology, they consider or recommended indefinite treatment or extension for those people. So how we use Rivaroxaban, we all know that. With the first 21 days, we give your patient 15 milligram twice a day, and then for the rest of the 6 months, we give him 20 milligram once a day, and then you extend your treatment by using 10 milligram once a day. If the patient has high risk or cancer, it's better to continue with 20 days. And by this, I will conclude. I'm ready for any question. Hopefully, I finished on time.
Thank you so much, Dr. Fahar. It was an amazing lecture. You summed up everything almost. A few questions in the chat box you've already answered throughout your lecture, but there is a question, if you don't mind. Are there any clinical or biochemical indicators of PST that we can look for to prevent it from happening?
To prevent PT, yes, it is very important question. So far, I am not aware about anything you can do for your patient except by treating your patient very well, and you start the treatment, make sure your patient is compliant with his medication, maybe referral to physiotherapy, rehabilitation, those things. But there is no medication yet to give your patient to prevent this. So the best, as we said, to prevent the DVT from happening by following the guidelines and by protecting your patient from getting the disease itself.
Okay. The second question, patients with recurrent non-provoked DVT with elevated immunoglobulins but negative thrombophilia, would you recommend switching them from warfarin to DOACs? This is a question there.
Yes, that's our discussion always with hematologists, like the hematologists, they like warfarin for their patient more if he has like any autoimmune disease. But like, as we said, you can use NOAC now, and we are very comfortable with NOAC. As for thrombophilia, be careful. Maybe warfarin is safer for your patient.
Would Dr. Waqar or Dr. Bakri would like to add anything to the questions?
I mean, I don't know if they meant antiphospholipid syndrome, if one of the titer is positive, because the guidelines really push for warfarin over NOAC, especially when you have a triple antibody positive. It's a no. I mean, some expert in the thrombosis area, they tell you if there is no compliance with warfarin, whatever, even antiphospholipid 1 or 2 titer positive, still you can use it. But for immunoglobulin, I'm not aware that warfarin is better than.
Well, actually, I have one case with antiphospholipid syndrome. He's still in the hospital. Actually, he came with he has COVID in his country 1 month ago. He came with hemoptysis. And we have discussion between the hematology, rheumatology, pulmonary, and me about what to do for this patient. And then we decide to put him on warfarin. And we observe him in the hospital till we get him therapeutic INR. We decided the INR should be on low side because he has recent hemoptysis between 2 to 2.5. But we decided warfarin is the place for him. Yes. And this is like, if you allow me, that's comment on the question was for Dr. Waqar before. Do you protect your patient from the first PE if he has antiphospholipid syndrome or not. The discussion was the patient we have, he has no PE before. And the discussion with the hematologist and rheumatologist, yes, protect him, put him on warfarin. Okay, even before the first episode of PE. That was the discussion.
The subsegmental one, okay.
Yes.
The last question, if you don't mind, if the thrombosis was an unusual site, especially in, for example, cancer active patients, what do you recommend the duration of the anticoagulation?
So he has a cancer and he has
An active
DVT?
cancer, and yet he has the thrombosis and
We cannot hear you, Doctora.
Seriously? Sorry. If the patient has an active cancer and yet he has
No, we cannot hear you. Can you hear her, Dr. Tariq?
Yes, I can hear her. Yeah.
Okay. Sorry, Dr. Bakri. So the patient is an active cancer and yet he has a thrombosis in unusual site. What would you recommend the duration of the anticoagulation?
It's exactly the same. You know, when there is active cancer, so usually all the guidelines, because he's still at high risk, so it's just to keep extending till remission if possible, or if the risk of anticoagulation outweighs the benefit.
Thank you so much, our speakers, Dr. Al-Hamsi, Dr. Waqar, Dr. Bakri. It was an amazing night, amazing sessions, very educational. I'd like to see you, inshallah, in the near future. And thank you again. Happy UAE Flag Day, everyone.
Thank you, Abir, and
Happy UAE Flag Day. Thank you so much.
Massalam.
Thank you.
Massalam.